According to the World Health Organization, liver cancer is the second most common cause of cancer death worldwide, and death rates have been steadily on the rise since the 1980s. The options and treatments for patients with advanced liver cancer are very limited, with the overall 5-year survival rate this year at 17%. Join us today as we meet with experts in the field of oncology and discover how a new investigational treatment option for patients with advanced liver cancer is making the rounds. I'm Erica Vetrini. Access Health starts right now. Fortunately, there are certain novel therapies currently in clinical trials that offer hope, and if effective, the promise of additional treatment options. It is known as a type of oncolytic immunotherapy, which involves harnessing our body's own immune system to fight cancer. Joining me today to help navigate the latest information is Dr. Laura K. Findice, Chair of the Department of Radiology at the University of Tennessee Medical Center. Thank you so much, Doctor, for joining us today.
Thank you for having me, Erica.
So there's a lot of information out there. Let's start with the basics. What is primary liver cancer?
Primary liver cancer is simply cancer that starts in the liver. It's called hepatocellular carcinoma, the most common type of liver cancer, which basically just means liver cell cancer. We call it HCC. There are multiple types of patterns of liver cancer. So liver cancer can develop as multiple small tumors within the liver. It can develop as a single big tumor in the liver. It can start as a small tumor and then grow big. This is important because it impacts the types of therapies that we can offer patients.
So we're going to talk a little bit about early detection, but first let's talk about risk factors associated with HCC. What are they?
The most common risk factor for HCC is cirrhosis or damage to the liver. The most common cause of cirrhosis in the United States and North America is alcoholism. We also have viral hepatitis, and so there are two types of viral hepatitis that are important, hepatitis C and hepatitis B. Hepatitis C is the most common. The most rapidly increasing segment of the population with HCC is patients with fatty livers. Obesity, diabetes are known to be independent risk factors for HCC, and it's because of development of fatty liver.
So now that we've identified the risk factors, let's talk about early detection. Is that possible with HCC? It
is a possibility. And the patients that we will screen for hepatocellular carcinoma are patients that are already known to be at risk. So we don't screen everybody. Really, screening procedures are just ultrasound of the liver every 6 months to look for those early nodules that are the sign of HCC. The reason it's important for those populations because of their very high risk is if we can find those tumors early, the options for treatment are much better.
Speaking of treatment, I know there's not been a whole lot of hope in this space until now. I know, Doctor, that you're involved with a ton of research and some clinical trials regarding the treatment of HCC.
It's true, Erica. There have been some really great developments, and I'm really excited to be able to share those with you.
Doctor, can we break down some of the conventional treatments for HCC?
Most patients, if they have a smaller contained tumor or just very few tumors, will actually recommend transplant. You always hear that, that the liver can regenerate itself. Well, the liver tries to regenerate itself, it tries to fix itself. And so there's a lot of cell turnover that's happening there, and cell turnover can cause a bad cell, and a bad cell can then become a cancer. Once your liver starts making tumors, your entire liver is at risk
compromised.
of making tumors.
Interesting.
If you're not eligible for transplant, there are other therapies that we can do. So if you have a small localized tumor that's kind of on the edge of the liver, a lot of those can be cut out surgically. The next step, if a patient's not eligible for surgery or if their liver's not healthy enough to have a surgery, what we can do is ablation. So ablation is where we actually take a long needle through the skin, straight into the liver using CT guidance, and use that probe to either heat or freeze the tumor to kill it. If you can't undergo an ablation, would be to undergo another type of liver-directed therapy, either chemoembolization or radioembolization. Chemoembolization is delivery of small beads into the circulation that goes to the tumor, and those beads have chemotherapy attached to them. It allows us to cut off the blood supply to the tumor and then also deliver a very high dose of chemotherapy to the tumor at that site. And then next in line is radioembolization, which is also beads delivered through the circulation to the tumor, but delivering a very high dose of radiation. So the beads themselves have radiation on them. If local regional therapies don't work, or if a patient's just not eligible for local regional therapies, there is a single oral chemotherapy agent called sorafenib that patients can take that's been shown to provide some survival benefit.
Okay, so simply put, local regional therapy is when we administer the treatment directly to the cancer cells or the surrounding area.
Yeah, that's right, Erica. It's actually a relatively new specialty. Interventional radiology or interventional oncology is a specialty where we use image guidance, so CT, ultrasound, X-ray, to navigate tools through the body directly to our targets to deliver therapy.
Access Health recently visited with Dr. Ricardo Lancioni at the Sylvester Comprehensive Cancer Center in Miami, Florida, to learn more about localized treatments for liver cancer.
So interventional oncology includes all minimally invasive therapies that are currently used to treat cancer. So the common denominators for this new branch of medicine are the use of a minimally invasive approach with minimal discomfort for the patient, the use of sophisticated imaging guidance that will allow precise targeting of tumors. This branch of medicine is now recognized as the fourth pillar in cancer care, along with the medical oncology, the use of drugs, surgical oncology, and radiation oncology.
Dr. Lancioni has been at the forefront of interventional oncology since its early application in the 90s and is heralded for his work in liver cancer as well as clinical trials. He recently joined the team of world-renowned experts at Sylvester to continue his contributions to this new age of cancer care that is designed to complement or work along with existing treatment options.
So years ago, the use of image-guided ablation was mostly relying on ultrasound guidance or CT guidance. So basically imaging techniques that allows you to see the tumor and localize the tumor, but not really to guide precisely in a 3D your device into the target. Currently, we have a variety of navigation tools, what we call the medical GPS. And this would simplify tremendously our job. And the concept of oncolytic viral immunotherapy is a game changer because you will be able to attack and destroy the cancer under the same minimal invasive approach, but at the same time inducing an immune reaction that will be systemic, meaning that the immune system will be able to attack and hopefully clear any other tumor cell anywhere in the body.
We'll hear more from Dr. Lancioni in just a little bit. This is exactly why I love doing this show. There's so many advancements happening in medicine and science, lots to talk about. For instance, in the news right now, we're hearing a lot about immunotherapy. Doctor, can you kind of break down what is immunotherapy and how it's applied to oncology?
Immunotherapy really gives us a novel way to approach treating cancer cells. Like we talked about before, we've had local regional therapies that treat the area of the tumor. And then with chemotherapy, we've had the ability to treat cell turnover, but it's been very non-specific to the tumor cells themselves. And now we can actually train the immune system to recognize tumor cells, remember tumor cells, and then kill those tumor cells wherever they are.
And what types of immunotherapies are being used specifically to fight HCC?
We can take cells out of your tumors, immune cells specifically out of the tumors, grow them in a lab, put them back into your body and use those cells to attack the cancer. Monoclonal antibody therapy, where we develop specific antibodies to tumor surface features so that the antibodies will actually go into the body, recognize the tumor, attach themselves to the tumor, and make that tumor a target, either kill the tumor or invite other cells from your body to come and attack the tumor. There are cancer vaccines. There's a vaccine against hepatitis B that's a preventive vaccine against hepatocellular carcinoma, which has been used for many years. But there are also treatment vaccines, and that's where this gets really exciting. So we deliver our agents to the region of the tumor, but we're still treating the area of the tumor. And with chemotherapy, we're treating cells all over the body. And so one of the reasons that chemotherapy is so difficult for people to go through is we're not only killing cancer cells, we're killing normal cells too, and that's what causes the side effects.
And this is why immunotherapy is so important. Now, you're involved in a clinical trial right now for HCC using this exact process at UT. Can you tell us a little bit more about the clinical trial?
I'm the principal investigator for our site on a trial called the FOCUS trial, which is a trial looking at Pexa-Vec, which is an oncolytic virus, looking at whether it'll improve survival and quality of life in patients with hepatocellular carcinoma. We're looking at the agent comparing sorafenib alone to use of this agent plus sorafenib.
We're back with Dr. Laura Finn-Dice, and we're talking about immunotherapy and how that is being applied to a worldwide phase 3 clinical trial. Doctor, can you first break down exactly how a clinical trial works?
When applying for FDA approval for an agent, there's a series of steps to go through. There's phase 1, phase 2, and phase 3 trials. Phase 1 and phase 2 trials are really focused on safety of the agent, basic effectiveness of the agent, optimizing the dosing of the agent.
And the FOCUS trial has now in phase 3, so that must mean that it's showing some promise.
Well, it means it's shown enough promise that we can now offer it to patients with disease and then compare the outcomes to the current standard of care therapy. The goal of this trial really is to determine whether we can improve long-term outcomes in patients who have hepatocellular carcinoma.
It's vitally important that each and every cancer patient be given the tools they need to improve their survival. Here's more from Dr. Lencioni in Miami.
So this field of interventional oncology has undergone a dramatic evolution over the past few years. I was actually the founding chairman of the Society of Interventional Oncology, and truly, with the advances in imaging and technology, the ability to precisely target and kill tumors has improved dramatically. The procedure to administer Pexa-Vec is actually quite simple because essentially it follows exactly the same rule that we would do for any biopsy. We have a specific device called the quadrifuse, which is a needle with multiple holes, and then we will place the needle, again by using state-of-the-art imaging, precisely into the tumor, avoiding, of course, any critical structures that are located in the vicinity of the tumor. And then we will inject the virus into the tumor. Once the needle is precisely located inside the tumor, we can deploy the tines that will come out from the cannula, and then we will slowly inject the solution containing the Pexa-Vec virus. Pexa-Vec has been shown to be safe. The phase 2 has also been completed. This was published in Nature Medicine 2 years ago. And these confirmed that patients who received intratumoral injection of Pexa-Vec had a much prolonged tumor control and much prolonged survival. And this was the basis to design now the ongoing phase 3 study.
Well, doctor, it sounds like the FOCUS trial is a huge step in the right direction, potentially changing the landscape for the treatment of HCC.
Well, Erica, that's the goal. The field of oncology has changed so much. Even in my own career, watching cancer become a diagnosis that was a short-term death sentence to seeing patients who live with cancer for years as a chronic condition has been so exciting. I feel really fortunate to be part of this right now. I feel like we're standing on the brink of this incredible understanding of how to treat cancer in a whole different way, and it's a wonderful thing.
For more information on the FOCUS clinical trial, visit Pexa-Vec trials.com, and of course you can log on to our website at accesshealth.tv. See you next time.